Hello, anesthesiologists. Thank you for your hard work today managing the respiratory systems of surgical anesthesia patients. Today, we will take an in-depth look at the clinical applications of the High-Flow Nasal Cannula, or HFNC. Buongiorno, anestesiologisti. Grazie per il vostro impegno odierno nella gestione dell'apparato respiratorio dei pazienti sottoposti ad anestesia chirurgica. Oggi analizzeremo in dettaglio le applicazioni cliniche della cannula nasale ad alto flusso, o HFNC. Welcome to this comprehensive CME review explainer. We all know the high-stakes environment of perioperative and intensive care. And honestly, managing acute respiratory failure is arguably one of the most critical aspects of our daily practice. So let's dive straight into the evidence and the sheer clinical utility of this transformative respiratory support interface.
For our explainer today, we're going to move quite logically through 5 key areas, taking us from the foundational physiological mechanisms right through to practical bedside titration, evidence-based applications, and finally, those absolutely crucial safety and monitoring protocols.
Right, starting off with Section 1, let's establish the clinical why. Before we can confidently twist dials at the bedside, we really need to understand the underlying physiological problems that HFNC is designed to solve.
To really appreciate HFNC, we have to look at the limitations of what we've used for decades. Consider the standard low-flow systems, your typical simple masks, standard nasal cannulas, or even non-rebreathers. These devices usually max out at a flow rate of around 15 liters per minute. Now picture an acutely hypoxemic patient in respiratory distress. Their inspiratory flow demand isn't 15 liters per minute. It can easily shoot up to 30, 40, or even well over 100 liters per minute. This creates a massive, glaring disparity. Because the conventional device simply cannot keep up with how fast the patient is pulling air in, they end up entraining room air from around the edges of the mask. What happens? That carefully selected fraction of inspired oxygen, or FiO2, drops significantly below what you think you're delivering. High-flow nasal cannula entirely bridges this gap. By pushing up to 60 liters per minute of actively heated and humidified gas, it completely meets or even exceeds the patient's inspiratory demand. This means you can dial in a highly precise FiO2 from room air at 21% all the way up to 100% without any room air dilution. It's a fundamental shift in how we deliver oxygen.
Now looking at this table, HFNC really boasts 4 distinct physiological superpowers. First up is anatomical dead space washout. Because we are continuously flushing the nasopharynx with high flow rates, we are effectively washing out that exhaled carbon dioxide. This drastically improves overall ventilation efficiency. Second, and this is absolutely brilliant for us as anesthesiologists, is the PEEP effect. Every 10 liter per minute increase in flow generates roughly 0.7 centimeters of water pressure when the patient's mouth is closed. So at 50 liters, you're getting a nice little splinting effect that aids alveolar recruitment. Third, as we just mentioned, is accurate FiO2 delivery. To put some numbers on it, a non-rebreather mask running at 15 liters per minute might actually only be delivering about 68% FiO2 to a dyspneic patient. But HFNC running at 40 liters per minute, that consistently delivers over 89%. You get what you set. And finally, number 4, humidification. Pushing high-flow, cold, dry air is incredibly damaging to the respiratory tract. By optimally heating and humidifying the gas, HFNC protects mucociliary function, heavily reduces the work of breathing, and makes secretion clearance so much easier for the patient.
Moving smoothly into Section 2. Now that we understand the why, let's talk about the how. Translating all that beautiful physiology into actionable protocols for your hospital floor.
Look at the delivery setup in this diagram. Notice the interface itself. It uses uniquely soft, pliable nasal prongs. Honestly, this is a massive game changer for patient compliance. We've all seen patients fighting tight-fitting non-invasive ventilation masks. The strap marks, the skin breakdown on the nasal bridge, the sheer claustrophobia. HFNC sidesteps almost all of that. The interface is exceptionally well tolerated. It leaves the patient's mouth completely free. They can speak to their families, they can take oral fluids, and they can cough effectively. This psychological comfort alone significantly reduces anxiety, which in turn reduces their subjective sensation of dyspnea and sympathetic drive. So, you're standing at the bedside. How do we initiate and titrate? We break it down into 4 practical steps. Step 1, start your flow rate somewhere between 20 and 35 liters per minute. Step 2, observe the patient. If their respiratory rate isn't settling or they still look like they are working hard to breathe, you want to titrate that flow upwards in increments of 5 to 10 liters per minute, all the way up to a maximum of 60 if needed. Here is the golden rule. Always maximize your flow rate first to meet the patient's inspiratory demand and generate that nice dead space washout. Step 3 focuses on the oxygenation. Adjust your FiO2 to hit your specific SpO2 target, but ideally you're aiming to maintain that FiO2 at or below 60% to prevent oxygen toxicity. Finally, step 4 is our exit strategy. Once the patient is clinically stable, you can start weaning the flow down. When they are comfortably maintaining saturations on a flow rate of 20 liters per minute or less and an FiO2 of 50% or less, they are generally ready to be stepped down to conventional low-flow therapy.
It is vital to note where we deploy this therapy. Because we are dealing with high acuity patients who could deteriorate rapidly, HFNC needs to be primarily utilized in monitored environments. We are talking about the intensive care unit, intermediate or high dependency care wards, and the emergency department. The device itself is elegantly simple to use, but the underlying pathology of the patient requires an environment where continuous hemodynamic and respiratory monitoring is just standard practice.
Right, on to section 3, and this is where it gets really interesting. Let us dive into the data-rich, evidence-based indications that are driving HFNC usage globally today. This is a heavily detailed table, so let's unpack these 8 key indications, because this is where the meta-analyses really speak volumes. First, acute hypoxemic respiratory failure. You simply cannot discuss HFNC without mentioning the landmark FLORALI trial. This trial was a massive paradigm shift. It demonstrated that in the specific subgroup of patients with a PaO2/FiO2 ratio of less than 200, HFNC didn't just improve comfort, it significantly lowered intubation rates and even reduced 90-day mortality compared to both standard oxygen therapy and NIV. This data firmly established HFNC as an early first-line therapy for conditions like severe pneumonia and early ARDS. Now, consider our immunocompromised patients. A fascinating post-hoc analysis of that very same FLORALI cohort showed a staggering reduction in intubation rates. We're talking 31% for those on HFNC versus a whopping 65% for those placed on NIV. That translates directly to mortality benefits, as avoiding invasive ventilation in these vulnerable patients prevents secondary infections. What about hypercapnic respiratory failure and COPD exacerbations? Now, intuitively, you might think, well, it doesn't provide active inspiratory positive airway pressure like BiPAP, so how does it help? The magic lies in that anatomical dead space washout we discussed. By constantly flushing out the CO2 from the upper airways, it improves alveolar ventilation. While NIV remains the gold standard here, HFNC is proving to be a highly effective, better tolerated alternative when NIV fails due to claustrophobia or mask intolerance. Moving to the peri-intubation phase. A robust meta-analysis covering 10 randomized controlled trials looked at preoxygenation. The results? HFNC alone or combined with NIV showed no significant differences in hypoxemia lates or apneic time compared to standard methods, meaning it's a perfectly safe and reliable tool for securing the airway. And post-extubation, large-scale RCTs, including a pivotal one with over 500 patients, confirm that in high-risk groups, HFNC significantly reduces reintubation rates compared to conventional oxygen. For your specific perioperative workflows, post-cardiac, thoracic, and major abdominal surgeries, moderate certainty-grade evidence now supports HFNC over conventional oxygen for preventing postoperative pulmonary complications. There's even a conditional recommendation for its use in obese patients where altered respiratory mechanics make atelectasis a real threat. And finally, palliative care. For do-not-intubate patients, it offers incredible, dignified relief from dyspnea while still allowing them to communicate with their loved ones and maintain oral intake in their final days.
Moving into section 4. Look, recognizing when HFNC is succeeding is incredibly satisfying, but as clinicians, recognizing when it is failing is absolutely critical. We need to secure the golden time before emergency intubation becomes a chaotic crisis. I want you to burn this specific number into your memory. 488. This is the threshold for the ROX index. The ROX index is quite simply one of the most brilliant, validated bedside tools we have for assessing HFNC success. You calculate it easily. Take the ratio of SpO2 to FiO2 and divide that entire number by the patient's respiratory rate. If you assess your patient after 2, 6, or 12 hours of therapy and the ROX score is greater than or equal to 488, the literature strongly suggests they have a high likelihood of successfully avoiding intubation. It takes the guesswork out of the equation and gives you a rapid, objective metric.
But what if they fall below that 4.88 threshold? This is when you enter what we call the golden time monitoring phase. If that number drops, your antennae need to go up, and you must rigorously run through this checklist at the bedside. You are watching intently for clinical signs of failure. Are you seeing thoraco-abdominal asynchrony? Is there a persistent or worsening tachycardia? And crucially, is there any sign of a deteriorating mental status?
These are massive, flashing red flags. HFNC is a fantastic bridge, but the data is explicitly clear it is not an effective rescue therapy if the patient is exhausting themselves. Prolonging the inevitable only worsens the hemodynamic collapse upon induction.
Decisive action requires a strict framework, which is perfectly visualized in this escalation flowchart. During hours 1 and 2, you are strictly assessing the initial clinical response. If it's inadequate, meaning the respiratory rate remains stubbornly high, the ROX index is low, and the work of breathing hasn't settled, you move into hours 2 to 4. Here, you must seriously consider stepping up to non-invasive ventilation to provide active pressure support. If by hour 4 or beyond, the patient continues to deteriorate or fails to stabilize, you must escalate to invasive mechanical ventilation. Delaying intubation because the patient simply looks a bit more comfortable on high flow is a well-documented clinical pitfall that actively increases mortality. Trust the timeline, trust your ROX index, and secure the airway early.
Finally, bringing us to Section 5, Infection Control and Safety. Let us address the safety profile, particularly the concerns regarding aerosol generation, which is understandably a priority in our modern clinical landscape.
There's a very common apprehension that pushing 60 liters of gas per minute into a patient's nose is going to turn the hospital room into a highly infectious viral wind tunnel. However, the empirical data is actually incredibly reassuring. Studies have meticulously tracked and measured aerosol generation distances using smoke and laser light scattering. At 10 liters per minute, the exhaled air dispersion reaches about 65 millimeters. But even at the absolute maximum flow of 60 liters per minute, the exhaled air distance only extends to 172 millimeters. This actually makes it demonstrably safer than a poorly fitted CPAP mask. Crucially, environmental contamination studies detected absolutely zero viral spread beyond 60 centimeters from the patient's face. Furthermore, simply placing a standard surgical mask over the patient's face and nasal cannula drastically mitigates any remaining particle dispersion, keeping you and your nursing staff perfectly safe.
Now, while it is generally exceptionally well tolerated, we do need to monitor for a few minor side effects as outlined in this table. Because of the sheer velocity of the flow, a small subset of patients may experience mild epistaxis, some nasal discomfort, or mucosal dryness. However, it's really important to contextualize this. In large-scale RCTs, the overall comfort scores for HFNC consistently and significantly beat conventional oxygen therapy, and severe adverse events are practically unheard of. The key takeaway here is maintenance. Just ensure the active humidification system's water chamber doesn't run dry. Underhumidified high-flow air will rapidly dry out the mucosa and instantly compromise patient compliance.
So we have covered a tremendous amount of ground today. We've explored the core physiological mechanisms, we've walked through step-by-step titration protocols, we've analyzed the grade-level evidence for its diverse applications, and we've highlighted critical monitoring parameters like the ROX index. By integrating these precise concepts into your daily practice, you have the power to actively prevent unnecessary intubations, vastly enhance patient comfort, and manage acute respiratory failure with a much higher degree of clinical precision. So my final question to you is this. Armed with this understanding of flow dynamics and the ROX index, how will you secure the golden time for your respiratory failure patients on your next shift? Thank you all so much for your time today, and thank you for your continued dedication to advancing the standard of patient care.